God forbid anyone would have to go through such a situation. But again, thank God for surgical sciences have progressed to an extent that the reconstructive microvascular surgeons are able to reimplant amputated limbs. What is reimplantation? Reimplantation is the reattachment of a completely amputated body part by re-establishing the arterial inflow and the venous outflow. If the parts are incompletely amputated, then it is called revascularization. Although the survival of the amputated digit depends on the patency of the microvascular repair, but reimplantation cannot be considered successful until function is restored. And function is related to the adequacy of the bone, tendon, nerve, and skin repairs, and not the least, the post-operative rehabilitation. Now, how do we classify this? Number one is according to the amputation level. Here we are mainly talking about the upper limb. So it can be a 4/4 amputation, a shoulder disarticulation, transhumeral elbow disarticulation, transradial wrist disarticulation, transmetacarpal, transdigit, and so on. The next type of amputation is according to the mechanism of injury. It can be an avulsion injury, it can be a clean-cut injury, it can be a crushed component, it can be a combination of all these. The third is according to the completeness of the amputation. It can be an incomplete or an partial amputation, or it can be a complete clean-cut amputation. All this is important because it gives an idea to the surgeon whether it is feasible or to explain it feasible to do and reimplant. It becomes easier to tell the prognosis to the patient. Obviously, clean-cut injuries and the ones with less crush component have higher chances of the survival of the reimplanted part. So that the surgery is a success, the surgeon must be aware of the anatomy, the veins, the arteries, all at the minuscule level, tendon, nerves, the bones, the ligaments, all of them. This is a picture of us in our department using the microscope for a microsurgical procedure. And yes, we need to know about the pioneers who started these microvascular surgeries. Buffo was the first person who reported it in 1840. Murphy again followed it, followed by Carroll. All these people, they formed long hours of practice, long hours of working in the lab, after which they would have done these microvascular anastomosis and then reported it. Clenard also performed a successful extremity revascularization. Clenard also did the first microvascular anastomosis of the digital artery in 1962. It was followed by Malt, and Komatsu and Tamai are the others who have helped us master the art of microsurgery. Yes, that's the part of the microvascular surgeon, but the people around or the layman, the patient, the attenders play a very important role in revascularization of the amputated limb. It needs to be brought to the hospital in a particular way, only then it can be reimplanted. The part needs to be thoroughly washed and all the contaminants needs to be removed. It needs to be wrapped in a moist gauze, after which it is put in a polythene cover. This polythene cover is again put in a polythene which has ice in it. It should not come in direct contact of ice. It is very important that the amputated part is brought to the hospital in such a manner. Only then the surgeons have time. This decreases the ischemia time and helps the surgeon work on the amputated limb for longer hours, and thereby contributing to the success of the surgery. Altogether, the surgeons, the attenders, if they have brought the amputated part at the right time, in the right manner, are we able to achieve this final result as shown in the picture? Thank you.